We will continue with part 2 of NICU. I want to talk a little bit about the post-term newborn. This means it is a baby that is born after 42 weeks gestation. Most post-term newborn are of normal size and health, but they could have the potential for intrapartal problems if they are large. They could have cephalopelvic disproportion or shoulder dystocia. I want to talk about postmaturity syndrome. Think about it. They are post-term. They should have come out a little bit sooner. So the placenta starts getting a little old, and old placentas impair nutrition and oxygenation. Babies that are exposed to poor placental function places them at risk for hypoglycemia because of the nutritional deprivation and depleted glycogen stores. It puts them at a risk for hypoxia. They could have meconium aspiration. It becomes at risk because the baby's meconium is in response to the hypoxia. They're hypoxic because of the old placenta. They can have severe meconium aspiration, which increases the risk of PPHN, pneumothorax, and pneumonia. They have polycythemia in response to the hypoxia. Babies make more red blood cells. They have seizures due to hypoxic states. They can experience cold stress, loss of or poor development of the fat, and they can have congenital anomalies. Post-term babies can actually begin to lose weight in utero. Post-term babies will have deep cracking and peeling of skin. These babies have long fingernails. They may be meconium stained. The cord may be meconium stained. Baby appears long and thin. The skin is loose. There's not much fat. So what causes postmaturity syndrome? It's not just a prolonged pregnancy. It involves advanced gestational age, placental aging, and subsequent insufficiency and continued exposure to amniotic fluid. See the really dry parchment-like skin with the skin cracking in this image? As I said before, fingernails are usually long and babies appear very long and lean. They don't usually have a lot of fat, so they have problems that regulating their own temperature. They may have stained nails and a cord, as we discussed before, due to the in utero meconium release. So I want to talk a little bit about the nursing care. It requires nursing care of a post-term baby. You want to monitor for cardiopulmonary status, keep them warm, monitor blood glucose, get the baseline H&H, and monitor the serum bilirubin. Let's talk a few minutes about the nursing care of the premature baby. So what is premature? That's a baby that's born less than 37 weeks gestation. So what's the big deal? Well, they have a variable immaturity of all systems: respiratory, cardiac, thermoregulation, GI, renal, immunologic, neurologic, and their reactivity states and behavioral states. We have the potential for cardiorespiratory difficulties. Incomplete development of muscular layer pulmonary arterioles lead to left to right shunting of blood through the ductus arteriosus back into the lungs. Left to right shunts are characterized by a back leak of blood from the systemic to the pulmonary circulation. As a consequence, the pulmonary circulation carries not only the blood that legitimately entered the right atrium and ventricle through the superior and inferior vena cava, but also the additional blood entering through an ASD, VSD, or a PDA. Blood volume and pressure in the pulmonary circulation become abnormally high. If the shunt is significant, there is progressive damage to the pulmonary vasculature and gradual development of irreversible pulmonary hypertension. The pressure in the pulmonary circuit may ultimately exceed the systemic pressure with reversal blood flow from the right side of the circulation to the left, also known as Eisenmenger syndrome. So lack of surfactant will cause alveoli to collapse and the infant becomes hypoxic. Surfactant decreases the ability of the lung to fill with the air because the alveoli collapses or becomes atelactic, which causes an increase in inspiratory pressure needed to expand the lungs. As a result, babies become hypoxic. Pulmonary blood flow is inefficient and their energy is depleted. Blood vessels can't constrict as well due to the lack of the muscle development in response to the hypoxia. Okay, I used abbreviations earlier. I want to kind of fill you in. ASD is atrium septal defect, VSD ventral septal defect, and then the PDA, which is the patent ductus arteriosus. So a patent ductus causes increased blood volume to the lungs, pulmonary congestion, respiratory effort, and then carbon dioxide retention, and then we have the bounding femoral pulses. So let's move on to thermoregulation. Well, they will lack glycogen stores in the liver to make their own heat. And they will also not have much of, or if any, brown fat to burn up for heat. So then we have the issue of cold stress. In cold stress, babies release norepinephrine to stimulate the metabolism of brown fat. Hypoxic babies don't have that exogen oxygen to do this, so they just get colder. They lack muscle mass too, so they can't even shiver. It's not shocking, I know, but heat loss is a major problem in preterm infants for two reasons. They have thin skin, remember? There's not a lot of subcutaneous fat, a big body surface area in relation to the weight, and the poor muscle development to flex their extremities. So basically, they can't make a lot of heat and can't hold on to what heat they do have. Okay, so let's discuss a few renal difficulties. Decreased glomerular filtration rate can occur due to decreased renal blood flow. GFR is proportional to gestational age. The lower the gestational age, the lower the GFR. GFR is also decreased in the presence of anything that has decreased renal blood flow, like respiratory distress, hypotension, and hypoxia. Anuria and oliguria result, inability to concentrate the urine. They have spilling of glucose at lower serum glucose levels. They have the decreased ability of kidney to buffer, which has the predisposing to metabolic acidosis. So we usually treat with sodium bicarbonate. Bicarb is excreted as a lower serum level, and acid is excreted more slowly. So after a period of hypoxia, the kidneys need more time to excrete the lactic acid that accumulates. They will have a delayed drug excretion time, so you want to adjust medication times. Let's review some immunologic alterations. So we have immature specific and non-specific immunity, which can lead to infection that often is the cause of premature delivery. Remember, babies should get immunoglobulin G, immunoglobulins for mom in the last trimester. When you're born before that, you don't get this. Or I should say the baby don't get this. Immunoglobulin A is found in breast milk. It's protective for mucosal surfaces of the GI tract. Preterms that are higher risks for infection than term babies. Also remember how fragile their skin is. Skin is your frontline defense against infection. That is why hand washing is so critical in the NICU. They don't have that good skin to prevent the nosocomial infections. Moving on to neurologic alterations. Myelination begins in the second trimester. There are rapid brain development which occurs in the third trimester. So common problems can be intraventricular hemorrhage, which leads to hydrocephalus, intracranial hemorrhage like grade 1, grade 2, grade 3, grade 4. There could be seizures, there could be altered behavioral states or reactivity periods. Obviously, the closer the term you are born or the baby is born, the better. The more mature the brain is. Delayed or lack of periods of reactivity due to poor condition of the newborn, they'll have more disorganized in sleep-wake cycle. Developmental care in the NICU is the way you take care of the babies that shapes who they become forever. Okay, I want to talk a little bit about fetal brain development. In the first 2 weeks of pregnancy, the fertilized egg is implanting inside of the uterus. In the third week, the heart, the backbone, and the brain of the embryo start to form. The further development of the brain continues in the fourth week of the pregnancy when the fore, middle, and hindbrain begin to be distinguished together with the optical stalk. In the fifth week, the brain continues to develop while the heart with the four chambers formed starts to function. During this week, the embryo gets facial features as well as arms and legs with the fingers. The brain hemispheres are formed in the sixth week of the pregnancy. In this period, the neural tube which links the spinal cord and the brain is also formed. Until the end of the seventh week of the pregnancy, the brain formation is almost completely finished. The eighth week of the pregnancy is characteristic for the big head, as well as for the hindbrain development, which controls the heart rate and the breathing. While in the ninth week, the nervous system is almost completed for its proper functioning, and in the 10th week, the fetus develops the genitals so that the sex of the baby can be seen through the ultrasound. In the 10th week, the brain starts to form even 250,000 neurons in a minute. In the 11th week, the spinal cord is defined, while vocal cords and taste buds are formed in the 12th week. The week 13 is characterized by the complete forming of the heart, the spleen, and the liver, while the fetus begins to use placenta to take nourishment from the mother in the 14th week. The hair grows on the skin in the 15th week, while in the 16th week, the mother can feel the kicking of the baby. Throughout the 17th, 18th, and 19th week of the pregnancy, the fetus develops the brain very rapidly, and the brain is now divided into the left and the right brain hemispheres. From the 20th to the 22nd week, the brain further develops, and now it is possible to recognize different sounds. In the 23rd week, the nerve cells join and form the nervous system, and starting from this week, the brain begins to control the other body functions. In the 27th week, the fetus may even be dreaming, and with the 28th week, the second trimester of the pregnancy is finished, with the brain completely formed. From the 29th to the 40th week, which is the third trimester of pregnancy, the brain only grows in size, and there are only a few brain developments. This concludes NICU Part II.